Good day, Mom. I am NAJERAH RACMAT, and together with Miss Natividad, we will be discussing gastric cancer. Gastric cancer is a disease in which malignant cancer cells form in the lining of the stomach. Gastric cancer consists of two pathological variants, the intestinal and the diffuse. The intestinal type is the end result of an inflammatory process that progresses from chronic gastritis to atrophic gastritis and finally to intestinal metaplasia and dysplasia. The diffuse type, characterized by the development of rhinitis plastica, is associated with an unfavorable prognosis because the diagnosis is often delayed until the disease is quite advanced.
Let us now discuss the risk factors of gastric cancer. So we have here age. So gastric cancer is common among older adults with a mean age at diagnosis of 68 years. Next is sex. Men are said to have a higher incidence of gastric cancer than women. Ethnicity is also one of the risk factors. So Hispanic Americans, African American, and Asian or Pacific Islanders are at higher risk of developing gastric cancer than Caucasian Americans. Diet is also one of the factors. So the people who have a diet high in smoked, salted, or pickled foods, or basically those who eat processed foods, and those people with diet low in fruits and vegetables have a higher chance of developing gastric cancer. Infection, specifically H. pylori infection, is a major risk factor for the development of gastric cancer. Other factors also include gastritis, pernicious anemia, smoking, obesity, achlorrhea, and gastric ulcers. Previous partial gastrectomy of more than 20 years ago is also said to be a risk factor of gastric cancer, and also genetics. So, a vast majority of gastric cancers are sporadic or occurring as a result of acquired, not inherited, gene mutations. However, it is understood that gastric cancers may have a familial component, for example, blood type A, and those with other first-degree relatives. It may be a parent, sibling, or child with gastric cancer and are associated with inherited cancer predisposition syndromes. So, here are some of the inherited cancer predisposition syndromes. So, we have hereditary diffuse gastric cancer, Lynch syndrome, juvenile polyposis syndrome, familial adenomatosis polyposis, and Peutz-Jeghers syndrome.
For the diagnostic test, first we have esophagogastroduodenoscopy. It is a test procedure to examine the lining of the esophagus, stomach, and the first part of the small intestine. The procedure uses an endoscope. Then, a biopsy can be taken through the endoscope of any suspicious areas that are seen. Second, we have cytologic washing. Cytologic washing is a type of exfoliative cytology that includes bronchial washings, urethral washings, peritoneal washings, and esophageal washings. These samples are received following a procedure either for the diagnosis, classification, and/or staging of benign and malignant tumors, or to identify infections. Third, we have barium X-ray examination of the upper GI. It is used to identify any abnormalities such as tumors, ulcers, hernias, pouches, strictures, and swallowing difficulties. Fourth, we have endoscopic ultrasound, or the EUS. It is an important tool to assess tumor depth and any lymph node involvement. Computed tomography scanning completes the diagnostic studies, particularly to assess pre-surgical resectability of the tumor before surgery is scheduled. CT scans of the chest, abdomen, and pelvis are valuable in staging gastric cancer. For the assessment, the physical examination is usually not helpful in detecting the cancer because most early gastric tumors are not palpable. Advanced gastric cancer may be palpable as a mass, so the ascites and hepatomegaly, or the enlarged liver, may be apparent if the cancer cells have metastasized to the liver. Palpable nodules around the umbilicus, called the Sister Mary Joseph nodules, are a sign of a GI malignancy, usually a gastric cancer. Gastric cancer is associated with few, if any, symptoms in the early stages of the disease. Symptoms of early stage disease may include pain that is relieved by antacids, resembling those of benign ulcers, and are seldom definitive. Symptoms of advanced disease are similar to those of peptic ulcer disease, such as dyspepsia, early satiety, weight loss, abdominal pain just above the umbilicus, loss or decrease in appetite, bloating after meals, and nausea or vomiting. Fatigue often occurs as a result of the cancer itself or blood loss from the lesions infiltrating the stomach or surrounding tissue.
Let us now proceed with the medical surgical management. So I'll be going to discuss the surgical management first, to be followed with the other medical management. So the first surgical management is total gastrectomy. So this procedure may be performed for a resectable cancer in the mid portion or the body of the stomach. So in this procedure, the entire stomach is removed along with the duodenum, the lower portion of the esophagus, supporting mesentery, and lymph nodes. After the surgery, a reconstruction of the GI tract is performed. So this procedure is called esophagojejunostomy. So in this procedure, anastomosis of the end of the jejunum to the end of the esophagus is done to reconstruct the GI tract. Next is radical partial or subtotal gastrectomy. So this is performed for a resectable tumor in the middle or distal portions of the stomach. Billroth 1 or Billroth 2 operation is then performed. So the difference between these two operation is that Billroth 1 involves limited resection. So since limited resection naman or gamay raman yung remove na parts of the stomach, it then offers a lower cure rate than Billroth 2. So Billroth 2 is a wider resection that involves removing approximately 75% of the stomach. So ang advantage ani Billroth 2 lang is that it decreases the possibility of lymph node spread or metastatic recurrence of the cancer. And last but not the least, we have the proximal partial or subtotal gastrectomy. So this procedure may be performed for a resectable tumor in the proximal portion of the stomach or cardia. However, total gastrectomy or esophagogastrectomy is usually performed in place of this procedure to achieve a more extensive resection. Now for the medical management, first we have the chemotherapy. So chemotherapy is mainly done to offer control of the disease or palliation, and in addition to surgery as adjuvant treatment of gastric cancer. So here are the chemotherapeutic agents. So we have fluorouracil, carboplatin, capecitabine, cystatin, docetaxel, epirubicin, irinotecan, oxaliplatin, and paclitaxel. We also have targeted therapy, which is a very important addition to the treatment of advanced gastric cancers. So for example, we have trastuzumab, which is a recombinant humanized anti-HER2 monoclonal antibody that is prescribed in combination with fluorouracil or capecitabine and cisplatin, which has shown an improvement in survival of patients with advanced gastric cancer who are HER2 positive. Other targeted therapies are currently being investigated for the treatment of advanced gastric cancers. For example, ramucirumab is currently in clinical trial in combination with olaparib for tumors considered to be inoperable. So this drug, ramucirumab, works by blocking the VEGFR2, which then reduces the blood supply to the tumor to decrease tumor growth. And lastly, we have radiation therapy. So radiation therapy is primarily used for advanced gastric cancers to slow the rate of tumor growth or for the palliation of symptoms related to obstruction, bleeding, and significant pain. These may also be used alone or along with chemotherapy before surgery to decrease the size of the tumor, or after surgery to destroy any remaining cancer cells and to delay or prevent recurrence of the cancer. So these are the common approaches of radiation therapy. We have the traditional external beam therapy and newer specialized approach to the external beam therapy. So the following are the specialized approach. We have the three-dimensional conformal radiation therapy, the intraoperative radiotherapy, and intensity modulated radiation therapy or IMRT. So this newer specialized approach, ilang ginabot ani is they precisely direct the radiation beam to the tumor site and thus limiting the damage of the neighboring tissues.
Now, for the nursing management, first we have to reduce the anxiety of our patient. So, a relaxed, non-threatening atmosphere is provided so the patient can express fears, concerns, and possibly anger about the diagnosis and prognosis. We have to encourage the family or significant other to support the patient, offering reassurance and supporting positive coping measures. We have to educate the patient about any procedures and treatments so that the patient knows what to expect. A nurse should promote optimal nutrition, so we have to encourage the patient to eat small, frequent portions and not irritating foods to decrease gastric irritation. Food supplements should be high in calories as well as vitamin A and C and iron to enhance tissue repair. We have to inform the patient about the ways to prevent and manage dumping syndrome and inform the patient that symptoms often resolve after several months. If a total gastrectomy is performed, injection of vitamin B12 will be required for life because intrinsic factor secreted by parietal cells in the stomach binds to vitamin B12 so that it may be absorbed in the ileum. This deficiency in vitamin B12 metabolism can result in decreased production of red blood cells. And then, if the patient is unable to eat adequately prior to surgery to meet nutritional requirements, parenteral nutrition may be necessary. We also have to monitor the IV therapy and nutritional status and record the intake and output and daily weights to ensure that the patient is maintaining or gaining weight. We have to assess for signs of dehydration like thirst, dry mucous membranes, poor skin turgor, tachycardia, and decreased urine output. We have to review the daily laboratory result to note any metabolic abnormalities like the sodium, potassium, glucose, and the BUN of the patient. For relieving pain, we must administer analgesic agents as prescribed. A continuous IV infusion of an opioid or a patient-controlled analgesia pump set to infuse an opioid may be necessary to mitigate post-operative pain. The frequency, intensity, and duration of the pain are routinely assessed to determine the effectiveness of the analgesic agent. We shall suggest non-pharmacologic methods for pain relief such as position changes, image distraction, relaxation exercises, back rubs, massage, and periods of rest and relaxation. In providing psychological support, let the patient express fears, concerns, and grief about the diagnosis, answer the patient's questions honestly, and encourage the patient to participate in treatment decisions. Some express disbelief and need time and support to accept the diagnosis. We should also afford emotional support and involve family members and significant others whenever possible. Project an empathetic attitude and spend time with the patient. Many patients may begin to participate in self-care activities after they have acknowledged their loss. In promoting home, community-based, and transitional care, we must educate patients about self-care. This includes information about diet and nutrition, treatment regimens, activity and lifestyle changes, pain management, and possible complications. A consultation with a dietitian is essential to determine how the patient's nutritional needs can best be met at home. We must educate the patient or caregiver about administration of enteral or parenteral nutrition. And if a chemotherapy or radiation is prescribed, provide explanations to the patient and family about what to expect, including the length of treatments, the expected side effects, and the need for transportation to appointments for treatment. And a psychological counseling may also be helpful. So that would be all for the gastric cancer. Thank you.
Pancreatic cancer begins in the tissues of your pancreas, an organ in your abdomen that lies behind the lower part of your stomach. Your pancreas releases enzymes that aid digestion and produces hormones that help manage your blood sugar. Factors that may increase your risk of pancreatic cancer include smoking, diabetes, chronic inflammation of the pancreas, family history of genetic syndromes that can increase cancer risk, including a BRCA2 gene mutation, Lynch syndrome, and familial atypical non-malignant melanoma syndrome. We also have family history of pancreatic cancer, obesity, and older age as most people are diagnosed after age 65. For the diagnostic tests, we have imaging tests that create pictures of your internal organs. These tests help your doctors visualize your internal organs, including the pancreas. We also have using a scope to create a ultrasound pictures of your pancreas. An endoscopic ultrasound uses an ultrasound device to make images of your pancreas from inside your abdomen. Another one is by removing a tissue sample for testing or biopsy. It is a procedure to remove a small sample of tissue for examination under a microscope. And lastly, we also have blood tests. Your physician may test your blood for specific protein or tumor markers shed by pancreatic cancer cells.
So, hello everyone, I'm Ross Campos, and for today, I'm gonna be reporting about the assessment, the medical surgical management, and nursing management of pancreatic cancer. So, first, here we have the assessment for the signs and symptoms of the pancreatic cancer. So, first, I have uh, divided the signs and symptoms between the classic signs and other signs. So first, we need to take note that I have placed a mnemonics here. For the classic signs, we have Pajau, and the other signs, we have Ravi. So for the classic signs, we have pain, jaundice, and weight loss. So these three classic signs occur in more than 80% of the patients. And we need to take note that these classic signs do not appear until the disease is far advanced. So other signs also include, on the other hand, we have the rapid, profound, and progressive weight loss, ascites, vague upper or mid abdominal pain or discomfort that is unrelated to any GI or gastrointestinal function and is often difficult to describe. So this pain also radiates as boring pain in the mid back that is also unrelated to posture or activity. It is oftenly progressive and severe, especially at night, and is accentuated when lying supine. So mo sakit yun siya duro sa gabi since mosamot man siya if maghayang matulog ang patient. And ang relief lang ani is or can be obtained by sitting up or leaning forward. So here it is interesting to note that insulin deficiency can be an important sign if present within the onset of these symptoms. So these are the following: the glucosuria, hyperglycemia, and abnormal glucose tolerance. So therefore, diabetes may be an early sign of pancreatic cancer. So we need to take note of that sign since the patient might not be experiencing only the diabetes mellitus but also pancreatic cancer. Now let us head into the medical surgical management of pancreatic cancer. So most of the management here revolves on the radiation and chemotherapy. So for the chemotherapy drugs, we have three known drugs that are used. So we have 5-fluorouracil, leucovorin, and gemcitabine. So gemcitabine is considered as the standard of care or drug of choice for metastatic pancreatic cancer. So next, we also have erlotinib in combination of gemcitabine. So erlotinib is an targeted anti-cancer drug. If paired with gemcitabine, it can demonstrate a slight improvement, especially in advanced pancreatic cancer patients' survivability. Okay? So, for the S1, an oral fluoropyrimidine, FOLFIRINOX, paclitaxel with gemcitabine therapy and radiation or surgery, we can also see an improved survivability rate for patients in clinical trials of these drugs. So, we can also take note of this management. Next would be intraoperative radiation therapy. So this can be done or considered, especially when the patient is undergoing surgery. So surgeon can or the oncologist can deliver high doses of radiation to the tumor site. So it might sound scary, but this management promotes minimal injury to other tissues and can be helpful in managing or relieving pain. So next, we can also implant interstitially a radioactive sources. However, this has high rates of complication. And finally, for this section, we can also insert percutaneously or by endoscopy a large biliary stent. So this stent can help relieve jaundice. Now, for the surgical management of pancreatic cancer, we can also excise or remove the tumor surgically. Typically, the tumors resected from the site are usually found in the head of the pancreas. So we need to take note also that this surgical procedure is usually extensive, and the total excision of the lesion is not usually possible. First, because the diagnosis is already late, that there is now an extensive growth of the tumor in the pancreas, and that secondly, uh, the cancer from the the cancer cells from the pancreas have or had already spread widely through metastasis, especially to the liver, lungs, and bones. So we are now only limited to palliative measures, which are discussed earlier, those radiotherapy and chemotherapeutic agents. Finally, for the nursing management, most of these management are considered to be palliative. So first, we have pain management and an attention to nutritional requirements of the patient. So these nursing management improve the level of patient comfort. So if we can still remember earlier that the patient might experience boring pain into their mid-back or mid-abdominal uh, mid-abdominal cavity, we can help the patient in positioning from supine to Fowler's or semi-Fowler's to prevent or to relieve pain. Next, we can also encourage the patient to use specialty mattresses. So this can be beneficial and protect bony prominences from pressure, since most of the patient uh, tend to limit their activity um, of daily living. So next, the pain associated with pancreatic cancer is no joke. So it is really, really painful. So we can also promote liberal use of opioids for palliative measures. So aside from that, we can also promote patient-controlled analgesia, especially for patients with severe and escalating pain. So since the patient is now considered to be palliative due to the poor prognosis and short survival rate, and of life preferences should be discussed and honored uh, among the patient and the significant others, no? So if appropriate, we nurses can also refer the patient to hospice care so that they can receive proper and comprehensive and holistic palliative care that can be individualized into their own needs. So that ends my report. Thank you so much for listening and have a great day.
Now let us proceed to intestinal cancer, where we are going to talk about tumors of the small intestine as well as the cancer of the large intestine, which is colorectal cancer. Tumors of the small intestine, whether benign or cancerous, are rare. Often, malignant tumors are not found until they have spread to distant places. Patients who have benign tumors are at risk of developing cancer. The diagnosis and treatment of intestinal cancers are made more difficult by the tumor's rarity, variety of kinds, and nonspecific nature of their symptoms. Small intestine cancer usually originates in the lining of the small intestine and may spread to the other areas of the body. Intestinal cancer typically begins in the duodenum or the upper portion of the organ. Here are the common types of small intestine tumors. First of all, we have the most common type, which is the adenocarcinoma. Adenocarcinoma develops in the cells that line the walls of the small intestine. Next, we have the sarcoma, which is a type of intestinal cancer that will develop in the connective tissue of the small intestines. Next, we have the gastrointestinal stromal tumors, which are variants of soft tissue sarcoma. Next, we have the carcinoid tumors that form in the lining of the intestines and are often slow growing. Lastly, we have the lymphomas, which is an immune system disease that may originate in the intestines. In my report, we are going to focus on the adenocarcinoma, which is the most common type of small intestine tumor. Here are the risk factors. First of all, the small intestine cancer occurs slightly more often in men compared to women. Next is that they tend to occur more often in older people, and they are most often found in people in their 60s and 70s. In the United States, African Americans are affected more often by these cancers compared to people of other races or ethnicities. Next, some research suggests that diets high in red meat or salted or smoked foods may raise the risk for small intestine cancer. People with celiac disease also have a risk for developing small intestine cancer. This is because by eating gluten, this causes the body's immune system to attack the lining of the intestines. People with celiac disease have an increased risk of a certain kind of lymphoma of the intestine called enteropathy-associated T-cell lymphoma. Next, for people with colon cancer, which means they also have an increased risk of getting cancer of the small intestine due to shared risk factors of the small and large intestine. Next, we have people with Crohn's disease. Crohn's disease is a condition in which the immune system will attack the GI tract, and this disease can affect any part of the GI tract, but most often it affects the lower part of the small intestine. People with this condition have a much higher risk of developing small intestine cancer, particularly adenocarcinoma, and these cancers are most often seen in the ileum, which is the last part of the small intestine near the colon. Next, we have inherited syndromes. First, we have the familial adenomatous polyposis, or FAP. In this condition, many polyps develop in the colon and rectum. If it is not removed, then these polyps will become cancerous, and more often than not, they can develop also in the stomach and the small intestine. Next, we have the Lynch syndrome, or the hereditary non-polyposis colorectal cancer, or the HNPCC rather. In most cases, this disorder is caused by a defect of a mismatched pair of MMR genes. Having an abnormal version of any of these genes reduces the ability's body to repair damage to its DNA. This will result to an increased risk of cancer of the colon as well as the small intestine. Next, we have the Peutz-Jeghers syndrome, or PJS. People with this condition develop polyps in the stomach and the intestines, as well as other areas which also include the nose, the airways of the lungs, as well as the bladder. They also have dark freckled-like spots of the lips, in your cheeks, and other areas. PJS can increase the risk of many types of cancer, including small intestine adenocarcinoma. Next, we have the MUTYH-associated polyposis. People with this syndrome will develop colon polyps, which will always become most likely cancerous if the colon is not removed. They can also get polyps in the small intestine, which raises the risk of small intestine cancer. Now, next risk factor would be people with cystic fibrosis. People with this condition have a severe lung problem. Often in people with cystic fibrosis, the pancreas cannot make the enzymes that break down food so that it can be absorbed. Therefore, they have an increased risk of small intestinal cancer. Now here, let us move on to diagnostic tests. First, we have the physical exam and health history, which is an exam to check general signs of health which includes checking for signs and symptoms of the disease, such as lumps or anything else that will seem unusual, a history of the patient, as well as health habits or past illnesses, as well as hereditary illnesses will also be taken. Next is an X-ray. For small bowel cancer, X-rays may be taken of the entire gastrointestinal system, including the esophagus, stomach, small bowel, and large intestine, as well as the rectum. Sometimes this person will drink a substance called barium, which can outline the esophagus, stomach, and small bowel on the X-ray and will help the doctor see tumors on abnormal areas. Now here is an example of the upper GI series with small bowel follow-through. As I said earlier, this procedure is where a patient will drink a liquid that will contain barium, and a series of X-rays of the esophagus, stomach, and small bowel will be performed. Now, as the liquid will coat the esophagus, stomach, and small bowel, X-rays are taken at different times as the barium travels through the upper GI tract and the small bowel. Next procedure is an endoscopy. This will help the doctor see the inside of the gastrointestinal system. The patient will be sedated while the doctor will insert a thin, lighted, flexible tube called an endoscope through the mouth and down the esophagus into the stomach and the small bowel. Of course, the patient will be sedated. If there are abnormal areas, the doctor can remove a sample of tissue and check it if it is cancer. This procedure will let the doctor see some but not all of the small bowel. That's why the doctor will usually recommend a video capsule endoscopy or a VCE. Now, in this method, the patient will swallow a small pill-sized capsule that will contain a tiny camera and light. Pictures will be collected from the capsule as it travels through the patient's GI system, and the capsule will exit the body during the patient's next bowel movement. Our next procedure would be a biopsy. Now, biopsy is the removal of a small amount of tissue so that the doctor can examine it under a microscope. The other tests can suggest that cancer is present, but only biopsy can make a definite diagnosis. Now, the person who analyzes a biopsy or performs a biopsy would be a pathologist, which interprets laboratory tests and evaluates cells, tissues, and organs so that they can diagnose if it is cancer. Next, we have the blood tests. Now, a number of the red blood cells in the blood can indicate whether cancer is causing any bleeding. We can perform tests for the liver and kidney function, and also the results will determine if either of those organs may be affected by the cancer and find out how healthy those organs are before having treatment for small bowel cancer. We also have the carcinoembryonic antigen level test or the CEA level test. Next, we have a colonoscopy. Now, the colonoscopy is similar to the traditional endoscopy. However, in colonoscopy, the endoscope will enter the body through the anus and the rectum into the colon so that it reaches the lower part of the small bowel. We also have a computed tomography scan or a CT scan. Now, this takes pictures of the inside of the body using X-rays taken from different angles. A computer will combine the pictures into detailed three-dimensional or 3D images that will show any abnormalities or tumors. Now, a CT scan can also be used to measure the tumor's sizes. Sometimes there is a special dye that is called a contrast medium that will be given before a scan so that it can provide more detail on the images taken rather. The dye can be either injected into a patient's vein or given as a pill or a liquid to swallow. Next, we have a PET or position emission tomography scan. A PET scan is usually combined with a CT scan so that it can be called a PET CT scan. A PET scan is a way to create pictures of organs and tissues inside the body. A small amount of radioactive sugar substance is injected into the patient's body, and this sugar substance will be taken up by the cells that use the most energy. Because as we learned, cancer tend to use energy actively, it absorbs most of the radioactive substance. However, the amount of radiation in the substance is too low to be harmful. A scanner then detects this substance so that it can produce images of the inside of the body. We also have exploratory laparotomy. In this procedure, a surgical incision is made in the abdomen to check for a disease. Sometimes tissue samples are taken out and often surgery will be performed at the same time to remove the tumor. Now let us move on to our assessment or the signs and symptoms. Here, this will include abdominal pain, intermittent pain, jaundice or the yellowing of the skin, and the yellowing of the skin, and the patient will feel unusually weak or tired, we have nausea and vomiting, unintentional weight loss, unintentional weight loss, as well as now let us move on to our assessment or other signs and symptoms include intestinal perforation, blood in the stool which may appear red or black, watery diarrhea, skin flushing, CBC will reveal a low HCP and HGB, elevated bilirubin, and elevated CAA levels, as well as anemia. Our next surgical procedure is a pancreatico-duodenectomy or a Whipple procedure. This operation can be used to treat cancers of the duodenum or the first part of the small intestine, although it is more often used to treat pancreatic cancer. In this procedure, the doctor removes the duodenum, a part of the pancreas, a part of the stomach, and nearby lymph nodes. The gallbladder and part of the common bile duct are also removed, and the remaining bile duct is then attached to the small intestine so that the bile from the liver can continue to enter the small intestine. This is a complex operation that will carry a fairly high risk of complications which can sometimes be fatal. Because of this, it is important that it is done by a specialist that has a lot of experience. So, some side effects from the surgery could include leaking from various connections that the surgeon has to make, infections, bleeding, trouble with stomach emptying itself after eating, trouble with digesting some foods, changes in bowel habits, as well as significant weight loss. Now, our third surgical option would be palliative surgery. Now, in this stage, the cancer cannot be completely removed because of how far it has metastasized, but surgery might still be a good option to help prevent or relieve some symptoms from the cancer. Often, these operations are done to relieve a blocked intestine, to decrease pain, nausea, and vomiting, and allow the patient to eat normally. First, we have bypass surgery. Now, bypass surgery is another option for a surgeon to leave the tumor in place and to reroute the normal parts of the small intestine around the tumor so that we can prevent or relieve a blockage. Next would be a stent or tube placement. If major surgery isn't a good option for some reason, sometimes an endoscope can be used to pass a fairly rigid tube called a stent down the digestive tract and into the blocked part of the intestine. The stent is left in place to help keep the intestine open and allow digested food to pass. If this can't be done, a thin flexible tube may be placed through the skin and into the stomach to drain it. The tube can be left in place to help prevent problems with nausea and vomiting. Now let us proceed to the medical management. First off, we have chemotherapy. Again, in chemotherapy, we use medications to destroy cancer cells and keeping them from growing, dividing, and making more cells. A patient may receive one drug at a time or a combination of different drugs at the same time. Chemotherapy can be sometimes given after surgery as an adjuvant therapy in treatment of small bowel adenocarcinoma. It is also prescribed to relieve side effects for people with advanced cancer. Now listed below are common regimens for small bowel adenocarcinoma. Now, unlike colon cancer, some studies for small bowel adenocarcinoma have shown a benefit to using taxane-based chemotherapy regimens, such as paclitaxel, docetaxel, and nab-paclitaxel, either as a single drug or in combination with gemcitabine or carboplatin. If surgery is not possible, the doctor may recommend chemotherapy to shrink the tumor to the point where it can be surgically removed. This is called neoadjuvant therapy. Sometimes chemotherapy combined with radiation therapy may be recommended for neoadjuvant therapy. This is called chemoradiation. Chemotherapy affects normal cells as well as cancer cells, so many people may experience side effects from this treatment. The side effects of chemotherapy depend on the individual and the dose used, but they can include fatigue, risk of infection, nausea and vomiting, hair loss, loss of appetite, and diarrhea. Now, we have immunotherapy. Again, to recap, immunotherapy uses the body's natural defenses to fight cancer by improving the immune system's ability to attack cancer cells. Now, in some people, small bowel adenocarcinoma may have a molecular feature called high microsatellite instability or mismatch repair deficiency. Tumors with these features can be treated with a type of immunotherapy called an immune checkpoint inhibitor if the disease has spread to other parts of the body and previous first-line treatment did not work. Immune checkpoint inhibitors that may be used to treat small bowel carcinoma include um, pembrolizumab, nivolumab, ipilimumab, and dostarlimab. Different types of immunotherapy can cause different side effects. Common side effects include skin reactions, flu-like symptoms, diarrhea, and weight changes. Now, here for our nursing management, according to our book, the nursing management of small intestinal tumors are similar to that of the patient with gastric cancer, such as providing specialized care, astute assessment for complications, individualized education for self-care, providing psychosocial support, and promoting optimal nutrition.
So now I'll be discussing colorectal cancer. So colorectal cancer is a disease in which cells in the colon or rectum grow out of control. Sometimes it is called colon cancer. For short, the colon is the large intestine or large bowel. The rectum is the passageway that connects the colon to the anus. The colon and rectal cancers are combined in term colorectal cancer, and most available statistics on these cancers are also combined. Colorectal cancer is the third leading cause of cancer in both men and women and is the leading cause of death from cancer in men and women combined. Now for the risk factors, it includes cigarette smoking, family history of colon cancer or polyps, high consumption of alcohol, high fat, high protein, and low fiber diet, high history of genital cancer or breast cancer, history of inflammatory bowel disease, history of radiation to the pelvis, history of type 2 diabetes, increasing age, male gender, overweight or obesity, previous colon cancer or adenomatous polyps, racial or ethnic background, specifically African American or Ashkenazi Jewish. Now for diagnostic tests is we have physical exam and health history and also imaging tests. We also have colonoscopy and biopsy. And lastly is the blood tests and the carcinoembryonic antigen level test. Now for the signs and symptoms is there is recent weight loss or gain. There is changes in appetite. There are changes in size, shape, caliber, or color of stools. There is difficulty passing of stool. There is nausea or vomiting. There is also blood in the stools, abdominal pain, bloating or fatigue, palpitations, and also skin color changes and unusual itching. Now for the medical surgical management. So stage 0 tumors typically have endoscopic or laparoscopic excision of their tumors. There is also a possibility of segmental resection with anastomosis, abdominoperineal resection with permanent sigmoid colostomy, temporary colostomy followed by segmental resection and anastomosis and subsequent reanastomosis of the colostomy, allowing initial bowel decompression and bowel preparation before resection. We also have permanent colostomy or ileostomy for palliation of unresectable obstructing lesions and construction of the coloanal reservoir called a colonic J pouch. Now for the nursing management is what they have to perform is to aid the patient in chemotherapy. We also have to provide care for the client receiving the radiation therapy and also provide care for the patient with bowel surgery. Including in our nursing management is the patient teaching. So first you have to teach the patient the care related to the abdominal incision and any perineal wounds. Give also instructions about when to notify the physician, especially if the wound separates or if any redness, bleeding, or purulent drainage, unusual color, or excessive pain is present. So we also have to advise the patient not to perform any heavy lifting. If the patient has a perineal incision, instruct her or him not to sit for long periods of time and to use a soft or waffle pillow rather than rubbing a rubber ring whenever in the sitting position. You also have to teach the patient about colostomy care, and also colostomy irrigation. And you also have to explain the purpose, action, and dosage and side effects of all medications prescribed by the physician.
Hello, this is John Maran Salva, and together with Precious HUERBANA, we are going to take over the report for brain cancer. What is brain cancer? But first of all, let us remember that a cancer cell has the ability to proliferate or cellular division without any stopping. So basically, a brain cancer is just a tumor that occupies space within the skull. They may grow as spherical mass or diffusely infiltrating tissue. Now, the effects of the brain cancer or the brain tumors are caused by the inflammation, compression, and infiltration of tissue. And once the tumor in the brain grows and divides rapidly, it can cause compression of the brain tissue, which can have massive neurological defects. And according to American Association of Neuroscience Nurses in 2016, there are over 100 types of brain tumors with an estimated 780,000 new cases each year. This includes 25,000 malignant and 53,000 non-malignant brain tumors. How does a brain cancer cause neurological defects? Now, the major pathophysiologic events or the principle behind brain cancer causing neurological defects is that there would be increased intracranial pressure and cerebral edema. Take note that the normal range for intracranial pressure is only about 7 to 15 millimeters of mercury. Any value above that can cause or can be a risk factor for brain cancer. Aside from that, there would be cerebral edema. Because of the tumor infiltrating the tissue, it can cause compression, hence there would be enlargement of the neurons or the cerebral edema occurs. So these two can cause focal neurologic signs such as headache, seizure activity, hydrocephalus, altered pituitary function. More than that, neoplastic lesions or cancerous cells in the brain ultimately cause death by increasing the ICP and impairing vital functions such as the respiration. The respiratory center in the brain is found in the medulla oblongata. And if any case, the tumor infiltrates the medulla oblongata, then it can cause respiratory compromise, or at worst case scenario, it can cause respiratory collapse. Since brain cancer is so broad, it is categorized into two divisions. Number one, we have the primary and the secondary brain cancer. Primary brain tumors originate from the cells within the brain. They are intrinsic tumors that is found within the brain. In adults, most primary brain tumors originate from the glial cells. Glial cells are the type of cells that make up the main structure and support system of the brain and the spinal cord. Whereas in the secondary or the metastatic brain tumors, they develop only from the structures outside the brain, and they are twice as common as primary brain tumors. Metastatic lesions have the unique ability to metastasize, meaning that cancerous cells from the original site may travel from the blood or from the lymph vessels, and they can go to the brain, hence causing brain tumor. And metastatic lesions to the brain can occur from the lung, breast, lower GI tract, pancreas, kidney, and skin, melanomas, neoplasm. Now, for our discussion, we're going to focus primarily on the primary brain tumors. Brain tumors are subdivided into four. We have the intracerebral tumors, which are subdivided into 5 categories. We have the tumors arising from the supporting structures of the brain, developmental tumors, and lastly, the metastatic lesions. The first classification of primary brain tumors is under the intracerebral tumors, and under that, we have the glioma. What is glioma? Glioma is a type of tumor that occurs in the brain and spinal cord. Gliomas, or the tumors in the glial cells, normally they begin in the gluey supportive cells or the glial cells that surround our neurons and help them function. We also have astrocytomas, which are graded as 1 and 3. They begin from the astrocytic cells, and astrocytic cells are specialized glial cells that outnumber neurons by over 5-fold. Astrocytes are very important in our brain because not only they regulate blood flow, but they also transfer mitochondria to neurons and supply the building blocks of neurotransmitters which fuel neuronal metabolism. Any tumor in these cells can cause a wide variety of effects, especially with impairments with normal metabolism. Second is we have the glioblastoma. The glioblastoma is an aggressive type of cancer that can occur also in the brain or spinal cord. They begin from the cells called astrocytes, also that support nerve cells, but glioblastoma can occur at any age, but tends to occur more often in older adults. We also have oligodendroglioma, low and high grades. Oligodendrogliomas are a rare type of brain tumor that develops also from the glial cells called oligodendrocytes. They are more common in adults and than in children. So the main symptom of oligodendroglioma depend on where the tumor is in the brain, but common symptoms, as always, is we have the headache and seizures. 4, we have the ependymoma. So ependymoma is also a type of tumor that can form in the brain and also with the spinal cord. As the name suggests, they begin in the epidermal cells in the brain and spinal cord, where the epidermal cells line the passageways where the fluid, specifically the cerebrospinal fluid, that nourishes or cushions our brain flows. Ependymoma can occur at any age, but most often occurs in young children. And lastly, under the intracerebral edema, we have the medulloblastoma. So medulloblastoma is a cancerous type of brain tumor. It develops primarily in the cerebellum, which is a part of the brain near the bottom of the skull. Second, we have also the primary brain tumors that arise from supporting structures. We have the meningiomas, from the word itself, meninges. Meningiomas are common benign encapsulated tumors of arachnoid cells on the meninges. They are slow growing, and they occur most often in middle-aged adults. Metastasis is rare in meningiomas, but benign meningiomas may be challenging to remove surgically without causing neurologic defects if the tumor is located at the base of the skull or surrounds the optic nerve, or in the rare case if the tumor is invasive. Another thing, we have the neuromas. An acoustic neuroma is a tumor of the 8th cranial nerve. The 8th cranial nerve, again, is the vestibulocochlear nerve. This cranial nerve is responsible for maintaining our hearing and our balance. If there is tumor in this cranial nerve, then of course the patient usually experiences loss of hearing, tinnitus, episodes of vertigo, and staggering gait. And as the tumor becomes larger, it becomes painful. So painful sensations of the face may occur on the same side as the result of the tumor's compression of the 5th cranial nerve. Under neuromas, there would be compression infiltration of the 8th cranial nerve, the vestibulocochlear nerve, as well as the 5th cranial nerve. And lastly, we have the pituitary adenomas. In this tumor, there would be pressure from a pituitary adenoma that can be exerted on the optic nerves. If there is tumor on the optic nerves, of course, there will be visual disturbances. Another thing about pituitary adenomas is that they can produce one or more hormones normally produced by the anterior pituitary. Take note that the pituitary gland is a gland that produces many hormones. So if there is tumor in this area, there will be hormonal hypersecretion, which can lead to hormonal imbalances. Several hormones that can be affected by this include the prolactin, the GH or the growth hormone, as well as the ACTH, adrenocorticotropic hormone, which can result in Cushing disease or thyroid stimulating hormone. Third classification of primary brain tumor is those tumors that are developmental. We have the angiomas. Angiomas, from the name itself, angio, meaning these are tumors that originate from the blood vessels or the lymphatic vessels. So the exact pathophysiology of this is unknown, but there may be a genetic factor that comes into play with this. Second, we have the dermoid, epidermoid, teratoma, and craniopharyngioma. So these tumors that are developmental in nature, they may normally begin as benign, slow-growing tumors, but they may occur in various structures of the skull, spine, and brain when normal developmental cells are trapped within the growing brain. And lastly, the most common type is we have the metastatic lesions in the brain. These are also known as the secondary brain tumors because they do not originate from the brain itself, rather they come from other sites such as in the lung, in the breast, and the GI tract. But once they travel through the blood vessels, through the lymphatic vessels, then these cancerous cells can infiltrate the brain tissue and can cause secondary brain tumor. That's the principle behind metastatic lesions. So any cancer can spread to the brain, but the types most likely to cause brain metastasis are lung, breast, colon, kidney, and melanoma. So in the Philippine setting, neoplasms of the brain and spine are relatively uncommon compared to the breast, lung, GI tumors, which occur at higher rates in Asian population. Now that we have discussed the underlying pathophysiologic events that highlights the principle behind brain cancer, let us go to the risk factors for brain cancer. Factors are anything that can increase the risk of a person to develop brain cancer. Risk factors may be predisposing or precipitating, and all of these information are sourced from the Core Curriculum for Oncology Nursing by Bryant 6th edition. The first risk factor that are listed is the disease-related. So a person is said to have an increased risk for developing brain cancer due to the effects of cancer itself. Remember the metastatic lesions, specifically in the lungs and in the breast. They can travel into the lymphatic vessels and blood vessels and all of these cancerous cells can infiltrate the brain tissue, hence causing secondary brain tumor. We also have the effects of posttherapeutic neuralgia or the PHN. Posttherapeutic neuralgia or PHN is basically a neuralgia that is intermittent or continuous nerve pain in an area of your skin previously affected by shingles. The pain may come and go or be continuous. PHN can be described as burning, stabbing, shooting, aching, throbbing, or like electric shocks, or in our vernacular language or in Bisaya, PHN can be described as very binhod. Other presence of infiltrative emergencies such as spinal cord compression, superior vena cava syndrome. Other diseases, we may have history of hepatic or neurologic dysfunction. And lastly, a person is said to have an increased risk for developing brain cancer if there is pre-existing neuropathies because of diabetes mellitus, because of HIV infection, because of vitamin B deficiency, which can manifest in the signs and symptoms of tingling of fingers and toes, jaw pain, foot drop, and muscular atrophy. Aside from that, not only a person is predisposed to having brain cancer if there are disease related, but also with the treatment related. Number one is, of course, chemotherapy, or the use of chemicals in order to destroy cancerous cells in order to stop the abrupt division of aberrant cells. This can also include immunotherapy. Side effects of chemotherapy and immunotherapy are manifested by the signs of symptoms of cerebellar dysfunction, stroke-like reaction, visual disturbances, loss of proprioception, vibratory sensation, and etc. And also, we have the side effects of radiation therapy or the use of radio waves in order to target aberrant or abnormal cell growth in order to stop its rapid cell division. Side effects may be manifested in the signs of symptoms such as ataxia, dysarthria, nystagmus, radicular pain, and there would be also pre-existing peripheral neuropathy related to radiotherapy or radiation therapy. Now lastly, we have the individual related risk factors. Number one, age, older than 60 years. Geriatric patients have an increased risk for developing brain cancer because of the effects of aging. Remember that aging can have a fast set changes in the body, specifically in cellular level. Once the body undergoes aging, the cellular metabolism, the cellular division will be changed also, which can predispose a client to have an increased risk for rapid cell division, hence cancer may develop. We also have social issues. We have the malnutrition, alcohol abuse, repetitive actions. There are a lot of scientific literatures that can have a correlative effect regarding malnutrition and poverty, especially the stress, which can have an increased risk for having brain cancer. In order to rule out or confirm the positive testing for cancer, there are several diagnostic tools that can be used for diagnosis. Number one tool that is often used to diagnose brain cancer is the CT scan or the computed tomography scans. A CT scan takes pictures of the inside of the body, specifically in the brain, using X-rays taken from different angles. And then the computer combines all of these pictures into a detailed 3D image that shows any abnormalities or tumors infiltrating the brain tissue. Second is the MRI scan or the magnetic resonance imaging. This is often dubbed as the golden standard for diagnosing cancer in the brain. In general, diagnosing a brain tumor usually begins with MRI, and once MRI shows that there is tumor in the brain, the most common way to determine the type of brain tumor is to look at the results from a sample of tissue after a biopsy or surgery, meaning that MRI as a golden standard for diagnosing brain cancer can also be used as a guide or supplement to other diagnostic tools. Next is 3D biopsy or the computer-assisted stereotactic 3D biopsy that is used to diagnose deep-seated brain tumors by the use of brain mapping technology. There is what we call as the needle biopsy, and this is done by the surgeon making a small hole in our skull and then guides a very fine and small needle into the tumor in order to take a sample. Now for tumors that are very deep inside the brain or that are widely spread throughout the brain, we may have a guided biopsy. So a guided biopsy is guided by either a CT scan or MRI scan. Next, we have the PET scan or the positron emission tomography that is used to supplement MRI scanning in many centers. More than that, the PET scan can help to show up a brain tumor by highlighting the areas of the brain where cells are more active than others. Next is we have the EEG or the electroencephalogram. An EEG is done, number one, to detect and locate abnormal electric activity in the brain, two, identify the location of a suspected brain tumor, inflammation, infection, bleeding, or head injury, and three, to diagnose and monitor diseases such as epilepsy, narcolepsy, which are very common symptoms of a brain cancer. Next is we have the cytologic studies. Cytologic studies may be utilized by aspirating CSF or the cerebrospinal fluid in order to detect malignant cells, as central nervous system tumors can shed cells into the CSF, resulting in metastasis. So the way this is performed is that the CSF will be aspirated using open surgery technique, and then the samples will be sent into the laboratory for testing in order to look for the malignant cells present in that fluid.
Moving on to the assessment, medical and surgical management, and nursing management for brain cancer. For the assessment, these are the general clinical manifestations of all brain cancer: increased intracranial pressure with headache, vomiting, visual disturbances, and seizures; localized symptoms with sensory or motor abnormalities, visual alterations, alterations in cognition, and language disturbances. Many tumors can be localized by correlating the signs and symptoms to specific areas in the brain. Here's a brief run-through on a few of such as documented by Hickey and Strayer in 2020. A tumor in the motor cortex of the frontal lobe produces hemiparesis and parietal seizures on the opposite side of the body, or generalized seizures. A parietal lobe tumor may cause decreased sensation on the opposite side of the body, or generalized seizures. A temporal lobe tumor may cause seizures as well as psychologic disorders. An occipital lobe tumor produces visual manifestations. A cerebellar tumor causes dizziness. A cerebellopontine angle tumor usually originates in the sheath of the acoustic nerve and gives rise to a characteristic sequence of symptoms. Brainstem tumors may be associated with cranial nerve deficits, along with complex motor and sensory function impairments. Moving along to the medical and surgical management for brain cancer, we have surgical management, with the main objective of removing as much tumor as possible without increasing the neurologic deficit. It also aims to relieve symptoms by partial removal or decompression. It also provides the opportunity to biopsy tissue to establish a definitive diagnosis. Next, we have radiation therapy. It decreases the incidence of recurrence of incompletely resected tumors. We have gamma radiation, which is delivered via an external beam to the tumor in multiple fractions. We also have brachytherapy, which is the surgical implantation of radiation sources to deliver high doses at a short distance. Then we have chemotherapy, which may be used in conjunction with radiation therapy or as a sole therapy, with the goal of increasing survival time. Malignant glioma is usually treated with 6 weeks of oral temozolomide during radiation therapy, followed by 6 to 12 months of oral temozolomide, and low-grade gliomas may be treated with 6 months of oral temozolomide alone. Autologous bone marrow transplantation is used in some patients who will receive chemotherapy or radiation therapy. And lastly, we have pharmacologic therapy. Corticosteroids are useful in relieving headache and alterations in level of consciousness. Other medications used include osmotic diuretics such as mannitol and hypertonic saline to decrease the fluid content of the brain, which leads to a decrease in ICP. Anticonvulsant medications are also used to treat and control seizures. Going to the nursing management for brain cancer, monitor for presence of headache and assess its characteristics. Encourage upright positioning and pain medications to manage pain. Even in the absence of seizure history, educate the patient and their family on the possibility of seizure and the need to adhere to prophylactic anticonvulsant medications if prescribed. Medications to alleviate nausea and prevent vomiting should be considered. And preoperatively, evaluate the patient's gag reflex and ability to swallow. In patients with diminished gag response, care includes educating the patient to direct food and fluids to the unaffected side, having the patient sit upright to eat, offering a semi-soft diet, and having suction readily available. Perform neurologic checks, monitor vital signs, and maintain a neurologic observation record. Space nursing interventions to prevent rapid increase in ICP, and reorient the patient when necessary to person, time, and place. The use of corticosteroids to control headache and neurologic symptoms requires astute nursing assessment and intervention, because many adverse effects can occur, including hyperglycemia, electrolyte abnormalities, and muscle weakness. Patients with changes in cognition caused by their lesion require frequent reorientation and the use of orienting devices, such as personal possessions, photographs, lists, and a clock, supervision of and assistance with self-care, and ongoing monitoring and intervention for prevention of injury. In patients with seizures, carefully monitor them and protect them from injury. Check motor function at intervals because specific motor deficits may occur depending on the tumor's location. In the presence of muscle weakness, an interprofessional approach, including the nurse and physical and occupational therapists, can be used to preserve muscle strength, promote range of motion, and facilitate independence and self-care. Assess for sensory disturbances, and any area of numbness should be protected from injury. Evaluate patient speech. Patients with speech deficits can be educated to use alternative forms of communication. Eye movement and pupillary size and reaction may be affected by cranial nerve involvement. An effort should also be made to conserve energy and promote rest, as fatigue is a common symptom during therapy.
Hello, good day. I am ALTA ALCULAR, and now let us proceed to spinal cord tumors. So according to Heike and Schreier 2020, tumors within the spinal canal are classified according to their anatomic relation to the spinal cord. So they include intramedullary lesions, which is within the spinal cord, extramedullary intradural lesions, which is within or under the spinal dura, and extramedullary extradural lesions, which is outside the dural membrane. So we have two types of tumors. First is the primary tumors. So these are usually intramedullary, consisting of astrocytoma or ependymoma. And meningiomas can occur as extramedullary intradural lesions. Next, we have the secondary tumors, which are far more common and are usually intramedullary extradural lesions. Tumors that occur within the spinal canal or exert pressure on it cause symptoms ranging from localized or shooting pains, weakness, and loss of reflexes below the tumor level to progressive loss of motor function and paralysis. Usually, sharp pain occurs in the area innervated by the spinal roots that arise from the cord in the region of the tumor. In addition, increasing sensory deficits develop below the level of the lesion. So loss of bowel and bladder function is common. Now let us proceed to the risk factors for spinal cord tumors. So although there are no risk factors that are conclusively associated with spine cancer, some experts believe that the following factors may influence the risk. So first, we have the exposure to high levels of electromagnetic radiation, especially during childhood. Next, we have hereditary cancer syndromes such as neurofibromatosis types 1 and 2, tuberous sclerosis, von Hippel-Lindau disease, Li-Fraumeni syndrome, Garlin syndrome, Charcot syndrome, and Cowden syndrome. Lastly, we have weakened immune systems due to congenital conditions, treatments for other cancers or to prevent the rejection of transplanted organs, or acquired immunodeficiency syndrome or AIDS. Now for assessment and diagnostic findings, neurologic examination and diagnostic studies are used to make the diagnosis. Neurologic examination focuses on assessing pain and identifying loss of reflexes, sensation, or motor function. Helpful diagnosis studies include CT scans, MRI scans, and biopsy. And according to Heike and Schreier 2020, MRI scan is the most commonly used and the most sensitive diagnostic tool, and it is particularly helpful in detecting epidural spinal cord compression and metastasis according to Kaplow and Ayeri 2016.
Next, we'll discuss nursing management, and this includes providing preoperative care. So there's assessment for weakness, muscle wasting, spasticity, sensory changes, bowel and bladder dysfunction, and potential respiratory problems, especially if a cervical tumor is present. And then we have assessment for coagulation deficiencies. A history of anticoagulation medication is obtained and reported because the use of these may impede hemostasis post-operatively. Then we have recognition of neurologic changes through ongoing assessments, pain control, management of altered activities of daily living, or ADLs, resulting from sensory and motor deficits and bowel and bladder dysfunction. Then we have patient education and breathing exercises, and they are demonstrated preoperatively since the patients have no alterations in mental state and ability due to anesthesia by this time. Also, discussion of post-operative pain management with the patient before surgery. Next, we'll be assessing the patient after surgery, and this includes monitoring for deterioration in neurologic status. Frequent neurologic checks are carried out with emphasis on movement, strength, and sensation of the upper and lower extremities. A sudden onset of neurologic deficit is an ominous sign and may be due to spinal cord ischemia or infarction. And assessment of sensory function involves pinching the skin of the arms, legs, and trunk to determine if there is loss of feeling, and if so, at what level. Vital signs are also monitored at regular intervals depending on the intensity of the condition. Next, we have managing pain. Pain is the hallmark of spinal metastasis, and patients with sensory root involvement may suffer excruciating pain, which requires effective pain management. So we can have administration of steroids like methylprednisolone, prednisone, and dexamethasone, and non-steroidal anti-inflammatory drugs or NSAIDs, which are commonly used to manage bone pain. This can be aspirin, ibuprofen, and naproxen. Then we can perform log rolling the client. How is this done? Well, the bed is initially kept flat, and then the nurse turns the patient as a unit, keeping the shoulders and the hips aligned and the back straight. And the sideline position, take note, is usually the most comfortable because this position imposes the least pressure on the surgical site, and placement of a pillow between the knees of the patient in a sideline position helps to prevent extreme knee flexion. Next, we have monitoring and managing potential complications. We can monitor for respiratory compromise from post-operative edema when there are tumors in the cervical area. We can also monitor the patient for asymmetric chest movement, abdominal breathing, and abnormal breath sounds. For a high cervical lesion, the endotracheal tube remains in place until adequate respiratory function is ensured. Also, the patient is encouraged to perform deep breathing and coughing exercises. We can also assess urinary retention. This is done by palpating the area over the bladder, or a bladder scan is performed. And we also have the nurse monitoring for incontinence because urinary dysfunction usually implies significant decompensation of spinal cord function. Next, we also have intake and output monitoring. Abdomen is auscultated for bowel sounds, and with leakage of cerebrospinal fluid, staining of the dressing may be present at the surgical site, which may lead to serious infection or to an inflammatory reaction in the surrounding tissues that can cause severe pain in the post-operative period. Also, bulging at the incision may indicate contained CSF leak, and the site should be monitored for increasing bulging known as pseudomeningocele, which may require surgical repair. We also have promoting home, community-based, and transitional care. First, we can educate patients about self-care. In preparation for discharge, the patient is assessed for the ability to function independently in the home and for the availability of resources such as family members to assist in caregiving. Patients with residual sensory involvement are cautioned about the dangers of extremes in temperature. They should be educated about the dangers of heating devices like hot water bottles, heating pads, space heaters, as their sensory integration may be impaired, causing them to lose the ability to detect dangerous stimulations and to react appropriately. The patient is educated to check skin integrity daily. For patients with impaired motor function related to motor weakness or paralysis, they may require training in activities of daily living and safe use of assistive devices such as the use of a cane, walker, or wheelchair. And the patient and family members are educated about pain management strategies, bowel and bladder management, and assessment for signs and symptoms that should be reported immediately. Lastly, we have continuing and transitional care. This includes referral for inpatient or outpatient rehabilitation, which may be warranted to improve self-care abilities. We also have a consultation for home, community-based, or transitional care, which may be indicated and provides the nurse with the opportunities to assess the patient's physical and psychological status and the patient and the family's ability to adhere to recommended management strategies. During the home visit, the nurse determines whether changes in neurologic function have occurred, and we can also assess the respiratory status and nutritional status of the patient. And the adequacy of pain management is assessed, and modifications are made to ensure adequate pain relief. Also, the need for hospice services or placement in an extended care facility is discussed with the patient and the family if warranted, and the patient is asked about preference for end-of-life care. In addition, social workers may be consulted to assist the patient and family members in identifying support groups and agencies that can provide help in coping with the disease process. That is the end of the report. Once again, this was Group B. Thank you for watching. If you have any questions or clarifications, kindly reach out to us. Thank you.